When a patient tells me I feel slowed down, like my body and mind are moving through molasses, I don't just hear fatigue, I'm listening for a pattern. Cold hands, weight changes that don't match the diet, hair shedding, brain fog, mood dipping for no obvious reason. That pattern often points me to the HPT axis, the hypothalamic-pituitary-thyroid system, the body's metabolic conductor. And if metabolism is the tempo of the body, the mind dances to that tempo. Today we're going to explore how the thyroid sets the pace for mood, cognition, and memory, and how stress and trauma can bend that rhythm. I'll start with a quick tour of the HPT axis and thyroid physiology. Then we'll connect metabolism to psychiatric symptoms. We'll look at bidirectional influences, how life stress and trauma can shift thyroid signaling, and how inflammation sits in the middle of that tug of war. After that, I'll walk through a functional assessment, what I call the full thyroid tree, and we'll close with holistic supports you can begin working with right away, plus where medication and augmentation fit when they're needed. Links to my blog, practice, and clinician training are in the description below. Think of the HPT axis as a three-step conversation. The hypothalamus gauges energy status, circadian input, and stress signals. It releases thyrotropin-releasing hormone, or TRH. TRH prompts the pituitary to secrete thyroid-stimulating hormone, or TSH. TSH stimulates the thyroid gland to make mostly T4, thyroxine, and a smaller amount of T3, tri-iodothyronine. T3 is the active hormone that binds receptors in the nucleus and turns metabolic genes up or down. But here's the nuance most basic panels miss. What matters clinically is not just how much the thyroid produces, but how well your cells convert, transport, and respond to it. In the context of conversion, in the liver, muscle, brain, and gut, enzymes called deiodinases transform T4 into T3, active, or reverse T3, RT3, which is a brake that blocks T3's entry. In the context of transport, T3 has to cross the cell membrane. Think of transporters as doorways. And finally, in the context of receptors and mitochondrial functioning, T3 then acts as a foreman, upregulating genes that run mitochondrial energy production, heat generation, lipid and glucose handling, and neural development and repair. In short, TSH is the thermostat, T3 is the furnace. If the thermostat looks fine, but the furnace isn't lighting, people still feel cold, physically and emotionally. Thyroid hormone sets basal metabolic rate. Turn it down and everything quiets. Gut motility slows, heart rate drops, body temperature dips, and the brain conserves. Turn it up, and systems hum faster. Low thyroid signaling, overt or subclinical, often presents as depressed mood, apathy, slowed thinking, word-finding trouble, sleepiness, and an I just can't get going energy profile. In the body, dry skin, constipation, heavy periods, weight gain or weight loss resistance, hair thinning, cold intolerance, and elevated LDL. In the context of high thyroid signaling, on the other hand, can feel like anxiety, irritability, insomnia, palpitations, heat intolerance, tremor, and weight loss. In labs, lower LDL, sometimes higher liver enzymes, and often elevated sex hormone binding globulin. Mechanistically, T3 modulates neurotransmission from serotonin and norepinephrine tone to GABA and glutamate balance. It supports myelination and synaptic plasticity and optimizes mitochondrial ATP output. When that cellular electricity sags, so do motivation and cognitive clarity. When it's too high, the system feels wired and brittle. Now, this part is crucial in mental health. Stress and trauma signal through the HPA axis, having to do with cortisol and inflammatory cytokines. Under chronic stress or illness, the body makes a strategic metabolic pivot, known as non-thyroidal illness syndrome or low T3 syndrome. Deiodinase activity shifts, converting more T4 into reverse T3, the brake, and less into T3, the gas. Cortisol and cytokines, think interleukin-6, tumor necrosis factor alpha, blunt TRH and TSH, and impair T3 action at the receptor. The net effect? A protective downshift, smart for short-term survival, rough on mood and vitality, if it becomes the new baseline. For trauma survivors, this may show up as a body stuck in conservation mode, fatigue despite sleep, hedonia, brain fog, and a tighter emotional bandwidth. It's not all in the head. It's a physiology-meaning loop. Experience shifts hormones and immune tone. Hormones shift metabolism. Metabolism shapes the mind. Flip the loop around. Low thyroid function increases allostatic load. When metabolism is sluggish, stressors feel heavier, recovery is slower, and inflammation rises, reinforcing the cycle. When metabolism is sluggish, stressors feel heavier, recovery is slower, and inflammation rises, all reinforcing the cycle. This is why approaches that lower inflammation and recalibrate safety, therapy, somatic work, breath, relationships, can rise T3 availability and function even before labs fully normalize. There are two special notes here, the first of which is with autoimmunity, with Hashimoto's and Graves' disease, for instance. Immune dysregulation often tracks with adverse stress histories or adverse childhood experiences and gut immune issues. Mood and anxiety symptoms can flare with antibody activity even before big shifts in TSH. Second one is in the postpartum setting. Rapid immune and hormonal changes can precipitate thyroiditis. The result can be a roller coaster, hyper to hypo, and postpartum mood symptoms. Screening matters. In an integrative psychiatry visit, I want the whole map, not just the thermostat. So there are some core thyroid labs that I'm interested in seeing. First is the TSH, a pituitary signal. Quote-unquote normal by population range doesn't always mean optimal for the individual. Second, a free T4 and free T3. These are the available hormones. Free T3 often tracks best with how people feel. Reverse T3, or RT3, is optional but extremely helpful if there's chronic stress, illness, or I feel hypo but TSH is normal. A relatively high reverse T3 with a low to normal free T3 suggests a conversion block or stress-adapted downshift. Thyroid antibodies like TPO antibody and the thyroglobulin antibody. Thyroid antibodies can help differentiate between Hashimoto's and Graves'. Antibodies can be active with a near normal TSH. Finally, I consider a total T3 if binding issues are suspected. There are some additional context labs that help to explore the metabolic and inflammatory terrain. These include a CBC, CMP, fasting glucose and insulin, hemoglobin A1C, and lipid panel. And for instance, an LDL often rises in hypothyroidism. And additionally, the sex hormone binding globulin often rises in hyperthyroidism. A high-sensitivity C-reactive protein gives a gauge of inflammation. I also like to check a ferritin because iron is required for thyroid peroxidase, B12, vitamin D, and magnesium. Selenium and zinc status are important because they're involved in deiodination. A morning cortisol or 4-point cortisol pattern if symptoms suggest an HPA/thyroid crosstalk. A celiac screen if there are gastrointestinal or autoimmune clues. In selected cases, iodine status is helpful. And finally, if there's nodules, a goiter, or compressive symptoms, a thyroid ultrasound may be helpful. In terms of clinical patterning, symptoms and vital signs such as resting heart rate, blood pressure, and temperature trends, physical signs such as brittle nails, lateral eyebrow thinning, and delayed reflex relaxation can be key. In terms of a medication review, it's important to note that lithium, amiodarone, iodine load, interferon, and even over-the-counter supplements can push thyroid up or down. For the life context, I'm curious about sleep debt, sustained caloric deficit, overtraining, recent pregnancy, grief, or trauma, as all of these can bias the axis. And then I need to consider, how do I think about optimal? Ranges vary by lab and person. I'm less dogmatic about the one perfect number and more interested in coherence between how you feel and the free T3, T4 availability, plus TSH tension, plus reverse T3 drag, plus the inflammatory tone. When those align, people usually say, "That's me." Now let's look at some different treatment-oriented lanes. First, let's look at nervous system safety. Therapy, somatic work, breath practices, and relational repair aren't soft add-ons. They change cytokine and cortisol activity, which changes conversion to T3. Next is sleep. Aim for regular timing. Circadian anchors, morning light, consistent wake times, support hypothalamic timing. This translates to steadier TRH and TSH signaling. Next is movement. Regular aerobic and resistance activity improves deiodinase activity and mitochondrial functioning. Avoid the overtraining trap. Chronic high-intensity interval training plus low calories can push reverse T3 up. For nutritional rhythm, extreme caloric restriction lowers T3. Smart deficits and adequate protein protect conversion. In the next treatment lane, let's look at nutrient repletion, building up the enzymes. Selenium is a cofactor for deiodinases and glutathione peroxidase. Think food first, Brazil nuts, seafood, and eggs before supplementation. Zinc is important for receptor function and conversion through deiodinase activity. Iron is very important for thyroid peroxidase. It's required for that activity. But at the same time, iron deficiency should be treated very carefully. Iodine is a substrate for hormone synthesis. Adequacy matters. Excess can flare Hashimoto's. Use food sources such as seafood, dairy if tolerated, and be cautious with high-dose supplements. Tyrosine, the amino acid backbone, is typically adequate with sufficient protein. Vitamin D, A, B complex, and magnesium support immune balance and receptor functioning. The third treatment lane is the gut immune thyroid axis. Address constipation, dysbiosis, small intestinal bacterial overgrowth, and celiac or non-celiac gluten sensitivity when it's present. The gut influences thyroid hormone enterohepatic circulation, which is the movement between the gut and the bloodstream, and immune tolerance. A trial of gluten reduction may help some with Hashimoto's. The strongest case can be made for this if the individual is celiac positive or if there are multiple autoimmune patterns. The fourth treatment lane is to lower the fire by looking at inflammation and thyroid peroxidase activity. This can be targeted through considering anti-inflammatory diet patterns such as Mediterranean-leaning, whole food, omega-3 rich patterns, selenium, which can reduce antibody titers in some Hashimoto's. Myo-inositol and selenium has data in subclinical hypothyroidism for TSH reduction, gentle support for mitochondria through CoQ10, carnitine, N-acetylcysteine, or ALA in select cases, can improve energy perception while the axis catches up. The fifth treatment lane is medications when indicated. If there is overt hypothyroidism, then levothyroxine or T4 is a standard and life-changing option for many. If conversion remains poor and symptoms persist, with appropriate T4 and lifestyle alignment, some benefit from combination therapy or T3 augmentation, especially in treatment-resistant depression under clinical supervision, should be considered. For hyperthyroidism, reflected through a low TSH and a high free T3 and T4, this requires its own pathway through antithyroid medications, definitive therapies, beta blockers for symptoms, and careful psychiatric support. There are a couple of psychiatry interfaces here, such as T3 augmentation, which has a long history of being used as an adjunct in depression. For anxious, activated presentations, we want to rule out hyperthyroidism before escalating stimulatory medications. It's also important to watch for lithium-induced hypothyroidism and to pre-treat or co-manage proactively. Let's put all this together in just a short case vignette. A 36-year-old with postpartum depression, profound fatigue, anxiety, and brain fog. The TSH is normal at 2.9. The free T4 is low to normal. The free T3 is low. The reverse T3 is mildly elevated, and TPO antibodies are positive. Lipids have crept up. The ferritin is 15, and sleep is fragmented. We build safety and rhythm. First, morning light, earlier wind down, partner-supported sleep swaps, and a trauma-informed therapy container. Nutrition shifts to adequate protein, iron repletion, omega-3s and selenium, and thyroid-friendly micronutrients. Gently, Zone 2 walks. Gently, aerobic activity, and 2 short resistance sessions are incorporated weekly. We reduce inflammation and support gut regularity. Because symptoms are severe and antibodies are active, we start low-dose levothyroxine with close follow-up. Consider myo-inositol and selenium, and collaborate on psychotherapy for birth trauma and identity transitions. Over 8 to 12 weeks, the free T3 rises, reverse T3 settles, energy and mood lift, sleep consolidates, labs improve, but more importantly, her lived experience does. And that's the point. So ask yourself, do my symptoms, energy, mood, cognition, temperature, bowel rhythm, fit a thyroid pattern? Do my habits support conversion to T3, sleep timing, protein intake, strength training, inflammation control, safe relationships? Have I seen the full thyroid tree? TSH, free T3, free T4, reverse T3 when appropriate, and antibodies, in context of iron, vitamin D, lipids, glucose, and C-reactive protein. If you're a clinician, remember, the HPT Axis isn't a single lab. It's a full story about energy and safety. If you're a patient, you deserve care that listens for that story and tests accordingly. Thyroid is where metabolism meets meaning. It's the quiet gear that sets our tempo, how quickly we generate energy, heal, think, and feel. When trauma slows the body to protect the heart. When trauma slows the body to protect the heart, we can think that wisdom and then help it safely speed up. If this was helpful, you'll find my longer blog on thyroid and mental health, details on my practice, and the training program for clinicians linked in the description below. I'm Dr. Nicholas Hatcher. See you next time.